and welcome to another short video, and this time I will be speaking about obstructive sleep apnea and snoring problems in children in particular. Okay, so snoring is very common in children and adults, and in this talk most of what I say pertains to children. So sleep apnea comes under the umbrella term sleep disordered breathing. So this involves or includes all children who snore and don't have any problems at all the way up to children who snore and breath hold during their sleep, and these are called apneas. Okay, so the typical sounds that your child might make are the usual snoring, and then they stop breathing. You won't be able to hear them. You might see them trying to gasp for air, and then all of a sudden and you get that catch-up breath. Okay, so that's an apneic episode with a catch-up breath. So is snoring or sleep apnea harmful to your child? So snoring on its own doesn't seem to affect children in the long term and is extremely common, and that's what we call simple snoring, which is not associated with apneic episodes or breath holding episodes. And sometimes from time to time your child will do that if they are unwell, have a cough and a cold, and their tonsils and adenoids will grow in response to the infection, which will block off the nose and reduce the amount of space in your throat, and therefore making it more likely that you will have these problems at night. But after a week or two, when they're better, that will go away in most cases. Okay, so you don't need to worry particularly about those episodes, as long as it's not prolonged and continuous for many weeks or months or even years. So medical studies have shown that if your child has sleep apnea, that's snoring and breath holding, it can adversely affect their development in several ways. Okay, so what happens is the oxygen level in your body falls and prevents restful sleep. So children can often find it difficult to wake up in the morning. They can fall asleep during the day, be especially tired, but children may not show that tiredness in the way that you and I might. They would be perhaps cranky or unreasonable, or just you might think that they're being naughty, to put it another way. But actually it's because they haven't slept well. Sometimes adults would generally tend to fall asleep during the day or be tired. Similarly, children can either get hyperactive towards the end of the day, or during the day can drop off and sleep as well. So it can be varied in children. So this in turn affects their concentration, their learning, their behavior, and not uncommonly this behavior is put down to a learning problem, or in some cases ADHD. And in severe cases, it can also affect their growth and their heart. Okay, so that's on the severe spectrum, or in children who have untreated obstructive sleep apnea. So how do I know if my child has obstructive sleep apnea? Okay, as opposed to simple snoring. So the signs of OSA, as we call them, in children include snoring, often with pauses, snorts, and gasps, as I previously showed, that catch-up breath. Heavy breathing while sleeping, quite often nighttime sweating, because the work of breathing, the work of trying to get the air inside them, causes them to burn energy, and as a response they would start to sweat and get hot. Restless sleep is quite common, and sleeping in unusual positions, getting up at night. Bedwetting is not all that uncommon due to obstructive sleep apnea. Daytime sleepiness or behavioral problems, as we discussed previously. Now, when do I need to see a doctor about snoring or sleep apnea in my child? So, your GP will often be able to provide you with advice and referral to an ENT specialist if required. In cases where you or your GP are unsure if there is a problem, you can either watch and wait and see what happens, because usually these sorts of problems and sleeping problems, improve as the child gets older, because as we get older, the adenoids and the tonsils, they tend to shrink, and the rest of your head and your face grow, and therefore the amount of blockage of your upper airways caused by adenoids and tonsils is smaller as a proportion of your head, because your head is, your body is growing, but the tonsils and adenoids don't grow along with it. They tend to stay the same size or even shrink. Okay, so your GP might ask you to watch and wait, or they might refer you to an ENT specialist if the problem is particularly bad. So your child may have one or more of the symptoms we discussed, okay, such as snoring, heavy breathing while sleeping, nighttime sweating, restless sleep, daytime sleepiness, or behavioral problems. It often helps to record your child's sleep on your mobile phone to show your doctor, and I've had several parents come and show me the sounds that their child makes, and it does help in the diagnosis in some cases if the diagnosis isn't quite clear, because not all parents are watching their children sleep at night, and they don't sleep in the same room as them. So what are the causes of snoring or sleep apnea? Okay, so when we sleep, the muscles in our neck and our throat, they relax. So this causes the upper airways to collapse and block off. If severe enough, the oxygen levels in our body drops, which is sensed by our brain. This then causes us to wake up ever so slightly, allowing the muscles in our neck just to stiffen up, and that stiffening up opens up the airways. We usually do not know when this is happening, because it's subconscious and at night and when we're half asleep. But when this happens throughout the night, several times an hour, we wake up the next morning groggy and feeling like we haven't quite slept or had a good night's sleep. And this occurs in adults and in children. But in children, you might find that they could be cranky and annoyed, or they could be bright and bushy-eyed, but then during the day you'll find that their behavior starts to take a toll, or their concentration, and you'll notice that something's not quite right, and you know when your child's not had a good night's sleep. In children, these problems are usually down to enlarged tonsils and adenoids. Reducing the size of the adenoids and tonsils usually improves the situation. Occasionally there are other factors that would make it more likely that your child has sleep apnea, including having Down syndrome, problems with the jaw, or especially large tongue, and rarely the cause of sleep apnea is caused by the brain, which is called central apnea, and that if we remove the tonsils and the adenoids, it doesn't always improve their sleep, but that's really uncommon and unusual, and there will be other signs in order to point you to that fact. Okay, if central apnea is going to be the problem, that is usually there are usually other signs that might point you in that direction. So an ENT specialist will be able to work out all these different various aspects of the history of your child and the problem, and will be able to work out the best management for your child based on the history and the clinical examination, which is pretty important. Sometimes I require a sleep study, which is required to help in the diagnosis if we aren't quite clear, or we might need it in order to find out how severe the obstructive sleep apnea is, so that when or if the decision is made to operate and remove the adenoids and the tonsils, or reduce the size of them, we can anticipate whether the child is going to run into problems immediately after the surgery within the first 24 hours or so. So occasionally we do require a sleep study to help us in that diagnosis. And that's a sleep study is a simple test. It's literally a probe that sits on your child's finger or on the toe and is wrapped up, and you essentially put it on before they sleep and then take it off in the morning, and throughout the night the machine is recording your child's pulse and the oxygen levels, and you do have the ability to also record when the child is up and doing things so that we know when your child is moving around during the night rather than assuming that your child is sleeping while the recording's taking place. Okay. So if you go to my website, you will see that I have written similar things to what I've talked to you about in this video, and also there are some diagrams in order to understand what I've said a little more clearly. So, does my child need their tonsils or adenoids removed? Okay, this is called the adenoid tonsillectomy procedure. So, in many children, this will be the case. So myself, an ENT consultant, will be able to determine if removing the tonsils and or adenoids in your child would be the best course of management or the first course of management. Occasionally there will be other factors involved, such as trying to improve your child's nasal airway if they're particularly blocked, but quite often it's simply the fact that the adenoids are so big at the back of the nose, blocking the airflow, that whatever you do to reduce the allergies in your nose or to reduce the swelling in the nose and the congestion, it just won't work, although it's worth having a go. So what does removing the tonsils and adenoids involve? So the first thing to say is that your child does not need their tonsils or adenoids. Okay, so once you're born, you don't need it. Okay, so you can see the video of me removing tonsils when I was at Alderhay Children's Hospital, and I remove it in a certain way, and my colleague removes it in another way, and I will come on to talk to you about the pros and cons of using one versus the other. Okay, so this was on BBC's Operation Ouch. So you can Google it, or you can go to my website, www.nottinghament.co.uk, and you can click on the link to watch to find out more. So that video was taken several years ago and demonstrates a couple of ways of taking the tonsils out. The procedure itself can be undertaken in a variety of different ways, but in most cases with children, I feel it is better to remove them using the coblation technique. Okay, so that it's a relatively new technique and requires suitable training and experience over a lengthy period of time. And the rates of bleeding and pain after the operation are far less. Occasionally, it isn't quite the operation that I would recommend for your child, depending on a couple of factors. But on the whole, most pediatric ENT surgeons or surgeons who perform this surgery should be doing it this way, certainly. Okay, so the recovery and getting back to normal activities is much quicker than removing it in the old style way. Okay, the rates of bleeding and pain are much less. I first started using this method about 10 years ago, and during our discussions in clinic I will talk to you about the different techniques and the pros and cons of them for your child, and then I will recommend the technique that I think will provide the best result for your child, and essentially you can decide which you would prefer after having heard the pros and cons of each. It's also very important when you choose your surgeon, whoever you wish to consult, whether on the NHS or privately, if they do offer the coblation technique. Okay, and if they don't, they are unlikely to provide you with the full facts. Okay, that's just what you would expect if they haven't got experience in using it, or they don't use it. There will be a reason, or they won't be familiar with the technique. So most pediatric ENT surgeons will use the coblation technique in almost all their cases where they remove tonsils and adenoids. So what will my child be like after having their adenoids and tonsils removed? So immediately after the operation, your child will have a sore throat, as might be expected. This will be controlled with painkillers. They will be encouraged to drink water at first, and then soon to have eat some soft food. Some children might try yogurt or try ice cream, and then we encourage more solid foods to be tried soon after, such as sandwiches, crisps, whatever your child likes, in order to get them to start chewing, moving their jaw, and to swallow. Okay, and that's going to help with recovery and the pain. Once they are eating and drinking, your child will be allowed home the same day, and it is unusual for your child to stay in overnight after surgery, but that can sometimes happen if their recovery is slow or if they have particularly bad obstructive sleep apnea, which we have picked up previously on various tests or on your history or your child's history. Okay, antibiotics are not usually required unless at the time of the operation I find that the tonsils are extremely infected looking. If you look at the back of the throat after the procedure, you will see where the tonsils used to be. You will see that there's a white covering of slough, and it looks doesn't look great, but that's normal. That's the healing tissues, and that's how it looks. That's not to say the area is infected, and it's the normal appearance. Continuing to eat solid foods helps remove that slough and scrape the back of the throat, and it aids in healing. Now, regular painkillers is the key, as directed by my medical team, and the team consists of pediatric nurses, anaesthetists, pediatric anaesthetists, and myself, and is paramount at least for the first week. Okay, if you miss a dose and wait for your child to complain of pain before giving painkillers, then they are unlikely to be able to swallow the painkiller, and therefore the cycle of pain and not being able to eat and swallow continues. So we don't want to get there. The throat discomfort gets better every day, but can increase after 4 or 5 days as the nerves are healing, and so just be aware of that. That's why I recommend painkillers regularly for the first week. Full recovery can take 2 weeks, so do allow 2 weeks off school, but with the coblation technique, some would go back to school after 10 days because they feel so well without any pain and back to normal. Okay, but to be on the safe side, I say 2 weeks. It is unusual for your child to bleed after the operation, but can happen in about 1 in 20 cases. And if you bring up more than a couple of teaspoons of fresh red blood, then please come into your nearest accident and emergency hospital. And that's just to make sure that the bleeding stops and doesn't continue. Okay, and very rarely 1 in 100 might need to go back to theatre to have bleeding stopped. In the following 2 weeks after surgery, expect some earache. That's normal, and that's caused by referred pain from the nerves in the throat, which also link to the nerves going to the ear. Some streaks of blood in the saliva are normal, but if you see a lot more than that, you will be advised what to do by your team before you go home from the hospital. So that's it. I hope that that's provided a brief glimpse into obstructive sleep apnea and snoring in children, and what you might want to do. If you do want further information, please do visit my website and email me, contact me through the form, or by all means get referred to me either on the NHS or privately, and I would be very glad to have a consultation and help you with any issues that you might have. Thank you very much for listening.